great pleasure and honor to be here for the Critical Lung Day. It's a great pleasure to be here, and this is a great topic, and we have great researchers and scientists so that we can all learn. And this is a non-profit event, and everybody can register. It's a free event. This session is about the adult distress syndrome. We have 3 topics that we believe are very relevant. We have Dr. Roldan from Peru, very well known because of his studies in lateral positioning. And then we have Dr. Roca. He is expert in ventilation. He is in Spain. And Adrian Ceccato, he is also in Portaudí, and he has also worked in a lot during COVID. We have very innovative questions, very interesting, and we will get started with Dr. Roca. And the questions will be at the end of his intervention. So, Dr. Roca, you have 15 minutes. Oriol, whenever you wish, you may start. Thank you so much, Luis. I will share my screen. Can you see my slides well? Yeah, perfect. Yeah. There's a little bit of echo in the back, though. These are my disclosures, and this is the agenda. So the first topic will be the mechanisms of NIRS failure and with high flow ventilation fails. And we need to scale up the treatment with intubation. A few years ago, this mechanism was described and how we can adjust the settings of the mechanical ventilation to avoid further damage. This was described in mechanical ventilated patients, but similar mechanisms are the same for patients treated with non-invasive support and without. Sorry, there's another mic open. Can we silence? So there are other mechanisms that act on those patients that don't have mechanical ventilation, but they have the same effect as you see here in this flow chart. I would like to show you as an example this case. This is an old paper of more than 10 years ago of Dr. Josida. Because of the heterogeneity of the lesion, of the injury, I don't know if you can see my pointer in zone 3 and 4, the air flows in the beginning of inspiration, and in zone 1 and 2, the air doesn't go in. So all of the volume goes here on the dependent zone, and then it goes to the non-dependent zone. And this is a chart. In the left, we see occult pendulum causing overstretch in the dependent lung. This, on the right, we see much more homogeneous breathing in the dependent and not dependent zone. Fillings is much more synchronic. This is an injury mechanisms that sometimes we do not take into consideration. What happens with the timing of intubation? It is one of the most difficult questions of the when. There are several studies that said that late intubation led to worse outcomes. More hours of non-invasive ventilation will take to more risk of death. And similar studies we see in this Korean study, and it opened the Pandora box. Here we see in other cohorts, these are the data of the validation cohort, comparing in the y-axis the relative risk of death in the hospital and the hours, the time to intubation. We see an increase in the risk as the hours go by. So there is an association of the timing of intubation and the risk of death. Why is this? Like we were saying before, there's a progression of the lesion, and we cannot avoid it with a non-invasive treatment. So if the patient has more than 25 of breathing rate for a longer time, then when we are intubating, they will have a higher pressure, a higher driving pressure. So this is a reflection of the lung damage. And we always have this debate. So will mechanical ventilation be beneficial in these patients? Will we be able to avoid the lesion? So when to intubate an acute hypoxemic respiratory failure would be the question. The correct timing is vital. We know that mechanical ventilation has risks, but also benefits. Mostly when the non-invasive respiratory support is not enough to stop the progression of the injury. So we have to analyze the respiratory variables. What catches our eye? This is Dr. Jarnell, and he used the UMC data to define different triggers for intubation. Here we see them on your slide. What we see here, that at 3 hours, that's what we are seeing in orange. At 3 hours in orange, less than 20%, except those that were in vasopressors, but less than 20% of the patient that met criteria for intubation, only 20% were intubated at 3 hours. So we have to understand this chart and the relevance of timing of intubation. Here we see the different colors and hours. Sometimes we are a bit slow in real life to intubate. So I believe we should intubate earlier. How to identify early NIRS failure? So this is the ROX index. Under a certain value, it will be associated with a higher risk of mechanical ventilation, and a higher value of 5. Very few had to be intubated. So there's a difference of both points. So here we see a ROX less than 3 and a ROX greater than 3. So we have to evaluate this through time. And we see the HFNC failure and success in green as the hours go by, and the ROX index reassessment should be considered. This is what we are testing currently in an RCT to try to answer this question. If we have to add the ROX index, and will it facilitate an early intubation and improve prognosis? Why this index? Well, we wanted to gather two parameters that are used to determine the failure of invasive support and gather it in only one index, and B, have an earlier intubation. Here we see the rocks and how to intubate according to this index. And on the left, the percentage of patients. 90% of these patients had to be indicated. So if we would have used the ROX index, we would have intubated these patients earlier and have better outcome. This is a little bit more complicated score, but it also can be useful. The HACOR score, heart rate, acidosis, consciousness, oxygenation, and respiratory rate. This score also helps us to identify those patients that have to be intubated early. Like you see here, the values, the NIV failure, NIV success. What are the mechanisms? As a concept, we are trying to decrease the effort that the patient is doing. This is a cohort that was monitored with esophageal catheters, and the swing of the pressure we see when the patient fails and the transpulmonary pressure increases because there's a lot of effort from the lungs, so the pressure goes up. In those that we see an improvement, that transpulmonary pressure was okay, and there was no increase or progression of the injury. Here, there's also a consideration of the inspiratory effort and the transpulmonary pressure. Here we see failure in this case, and here we see success. We can also use the diaphragm ultrasound to analyze these patients. If they can thicken the diaphragm with non-invasive respiratory support, they will fail. Those that the diaphragm is not so thickened, they can hold on better. This is an analysis of dyspnea and CO2, PaCO2. We do not use this kind of catheters in patients that do not have mechanical ventilation. But a low CO2 is very important because it indicates the effort of the patient. Here we see those patients that have a low CO2 are benefited the most. So what we have said before, and we've changed the paradigm, we have to be a bit more aggressive during the monitoring, not during saturation. We have this as an indicated measure.
Another important parameter is oxygenation. These are data from SLANG SAFE, treated with non-invasive, and we can see that even though here, when all patients were considered, there was only a trend to that the non-invasive could be harmful. The curves separate when we look at the subgroup of patients that are more hypoxemic, those that have a PaO that are lower. These will probably not benefit from non-invasive respiratory support if we cannot correct hypoxemia for non-invasive support. we will have to go to invasive support. And this is something that we can see over time. This is also a study from Takeshita that generated 2 models of lesions. These are intubated patients, but only to see the harm generated by inspiratory spontaneous effort when the lesion is mild or when the lesion is severe. And you can see the severe at the bottom, the mild at the top. And when we preserve at the bottom to the right, spontaneous inspiration in presence of a severe lesion, the lesion is magnified, while the exact opposite happens in mild lesions. And the severity of the lesion is defined basically by the degree of hypoxemia. Another thing we need to monitor is the respiratory tidal. And this could be an indirect measure of effort or inspiratory drive. Those patients that when we have non-invasive and despite the support version have elevated inspiration, they have more probability of failing. And once again, when we see if this happens both in patients with mild hypoxemia or moderate to severe, what we see is that the effect is focused basically in those patients that have hypoxemias that are moderate to severe. Here, it's also important to highlight the importance of the PEEP level. These are ventilated patients, and what we see is that if the PEEP is able to recruit the lung and have a positive mechanical effect, the effort required by the patient to have the same amount of air go into the lung is lower because the mechanical characteristic of the lung have improved. Now we will need to determine what level of PEEP is required by the patient, because if they are a recruiter, and let's understand the higher the levels of PEEP to improve respiratory effort and to make the success of respiratory support better, the non-invasive one. This one, they compare 2 levels of PEEP, and you can see some patients with higher PEEPs that achieve to reduce the volume and inspiratory effort and improve the transpulmonary pressure. And this also had an inflammatory effect. The lower the PEEP, these yellow segments that you see in the last lung correspond to areas with inflammation. And lastly, it is also important to look at the phenotypes of the patients. And this is a secondary analysis that we did with a cohort of patients that had great phenotypes in inflammatory terms in bilateral infiltrated patients with respiratory insufficiency treated with high flow. And we divided into 2 clusters, 2 different clusters. One with high level of inflammation. We measured ST2L6 markers of epithelial markers, endothelial markers, the rates and SPD, and also the ID8. And what we saw is that we could clearly define these 2 different phenotypes at a biological level, but we cannot define them clinically at the bedside because they were identical. None of the burial, SOFA, PiO2, respiratory frequency that showed a difference between the 2. What happens is that these patients had very marked differences in terms of outcomes. Those that had the hyperinflammatory phenotype required to be intubated more than 50%, whereas the others had only 30% of need for intubation. And mortality was absolutely different, from almost 10% in the not hypoinflammatory one, whereas the hyperinflammatory reached almost 50%. I'm about to finish, Luis. And biologic activity generated underlying to all of these mechanical alterations is also important to be able to contribute to the protecting the lesion. So in summary, there's a large amount of parameters that we can monitor to try to identify as early as possible those patients that are going to fail with non-invasive respiratory support, to be able to minimize or improve the outcomes and minimize complications from respiratory variables to circulating markers and scores. And we might have to design a study that compares early intubation versus a late intubation strategy, or an early strategy where the thresholds to determine intubation are more narrow and less permissive, and perhaps with a late intubation that considers non-invasive intubation. And that is something that we have to think about, and that probably we need to do. And I will end with 3 conclusions of the paper by Kevin Lee. 2 are mine. I participated in the paper, but they are basically his, like Christian and Lee, that summarize what we have been mentioning. There are multiple physiologic parameters, biomarkers, or scores that have shown that they can be valid to identify these patients. But we need to establish or validate these clinical triggers to be able to guide the process on intubation, with the objective of minimizing the harms of mechanical ventilation and identifying those patients that truly benefit from early intubation to see if they improve their results. Thank you very much. And I'm willing to answer any question. Thank you, Oriol. No, we have time for one question from the audience. I don't know if we have any questions in the chat, and I see that we don't. Otherwise, I'm going to ask. Oriol, I think that it's excellent and very useful that you are researching intubation criteria, because to extubate, well, we have many, many scientific papers, etc., but not to intubate. So my question perhaps doesn't make a lot of sense. But since there has been so much controversy during COVID, when to intubate, not to intubate, and all of these things, and seeing your presentation, so what do you think that was the best option during COVID based on these recent works and the last review? And then we have the question from the chat. So if you can answer this, I will allow for another question. Well, my vision is biased because perhaps I only have in mind those patients that they were mentioning from other hospitals, for example, or that they mentioned from our own. I believe that the faster we were at intubating, the best were the outcomes for the patients. And Adrian might be able to mention this with Jimenez Luz and COVID database. There are a lot of data of patients with COVID speaking about early intubation. That does not mean before meeting criteria, but once the criteria were met. So what we knew was that for the logistic reason, whether they were on the floor, they told us later, or 5 days, they had non-invasive. At the moment of the intubation, it was prone and extracorporeal support with a lot of unavoidable facts because the lung was already stone hard. So we can discuss what is the correct moment, but we can discuss whether the criteria could be 100 or 80 in PAFI to consider intubation, plus respiratory rate of 30 or 35. And there will be like a gray zone. But what we cannot discuss is that a patient, because they have a PAFI of 60 and a respiratory rate of 35, and saying they're not choking, we cannot do it because it does produce damage on the lung, even though they don't have the feeling of generating that harm. I have a 5 seconds. When to intubate a patient with severe COPD that doesn't respond to self-flow, that is hyperinflated and with hypoxemia? Well, the reason is when to intubate, or if we need to intubate. The same criteria than the hypoxemic patient with COPD. If the reason is not exacerbation of the COPD, then they have the same criteria than a hypoxemic patient without COPD. Great great presentation. We go to the next one. Dr. Rowan from Peru. Dr. Roman from Peru will talk about a topic that is very important. Let me see if we can see the exact title. which is lateral positioning prone in patients with distress. Lateral, sequential, lateral, sequential, prone as a way of maneuver for recruitment. Recently published work with international authors, and will give us the clinical recommendations. Thank you very much, Nadine, for participating really in this long day. You have 15 minutes. Thank you, Dr. Blanch. It's always a pleasure to see you. And I greet all participants in this event, and thank you for allowing us to share this short experience on the use of lateral positioning as a recruitment maneuver. Give us a second, please. So, Rolene, continue, please. The audience is seeing you perfectly. So, some theoretical important foundations. We can define recruitment as the opening of forced or collapsed lungs forced by an increase in transpulmonary pressure. And the transpulmonary pressure is equal to the difference between the alveolar pressure and the pleural pressure. And based on this equation, I could increase the transpulmonary pressure, increasing the alveolar pressure, basically through the use or an increase of the airway, such as when we use sustained insufflation like CPAP 40/40, for example, or progressive increases of PEEP and inspiratory pressure. But also, we could increase the transpulmonary pressure, reducing the pleural pressure, and this through position changes. And we have two typical examples that are prone position, widely known by all, and the lateral positioning. And this last one is what we're going to focus on during my presentation. And just to better understand the concept, we have an axial view of a chest, a CT, to see how the different components of the transpulmonary pressure work, the alveolar and the pleural pressure. The alveolar pressure is always the same one in the different lung regions. However, the pleural pressure will depend basically of the severity and the diameter of the gravitational axis. In supine position, it will be the anterior posterior position. So we generate a lower pleural pressure and greater in the dependent areas. So there will be a transpulmonary pressure that will be greater in the non-dependent areas and greater in the non-dependent areas and lower in the dependent areas. So how to apply this of the lateral positioning? In this example, now we have a patient in lateral decubitus, right or left, with an angle of 30 degrees. And here, what we see is, Doctor, are you passing the slides? We cannot see the slides going by. We cannot see that you're passing the slides. What number slide are you on? We don't see that here. Let's see. Can you see it now? So I'm going to recap. Altering the gravitational axis, when I place the patient in lateral position, this axis is greater than the anterior posterior axis in supine position. So I alter the gravitational gradient. So the transpulmonary pressure of the lung that goes upward in the non-dependent region is lower. Therefore, applying this equation, the transpulmonary pressure of the lung that goes upward is greater. That will generate pressure that can allow opening the alveoli that were collapsed in the supine position. So that is the foundation of what we would do to recruit the patient. The other important point that is fundamental is that we must program an adequate PEEP level for two reasons, so that there's no collapse of the lung that is placed in the dependent region when the patient is in lateral position. And the second reason is to maintain the benefit achieved of the recruitment maneuver when we place the patient in lateral position after we return them to supine position. So this is a point that deserves more research, but it is fundamental here. So based on this and the times of the COVID where there was a large burden of the work and patients were in inadequate environments with not a lot of staff and inadequate environments, we have a hypothesis. The hypothesis is that lateral positioning checked sequentially could act as a way of recruitment as long as we had an adequate level of PEEP that maintained the beneficial effects. So we did a study in patients with COVID, with moderate or severe distress from COVID, and we assessed the physiological effects of the strategy. We enrolled 15 patients. We placed them, as you see in the graph, in a sequential manner of supine lateral first, depending on the place that was altered. And to start with the lung upward, the most severe one, then we returned to supine. We changed the lateral to the other side and then supine again. And there we assessed the respiratory mechanic, both the overall and the regional, the gas exchange. We saw the deviation with the use of ultrasound and electric impedance, and we assessed hemodynamic tolerance. On this graph, to look at this video, I hope we can run the video. We see the use of ultrasound. We used ultrasound to assess how the lung was gaining air again. When we go to supine to decubitus with the left lung up, we could see how the air came into the lung. There were some B lines and everything looked really good. So I want to show this clinical case that better illustrates our protocol. Here we have a sequence of recanalization. We start with supine position. Each step lasted 30 minutes. Here, since the involvement was greater in the left lung, we placed in right lateral decubitus of left lung upward, and that is how the sequence started. We returned to supine. We left in the opposite or contralateral decubitus, and then in supine again. And on the second line, we have a ventilation map based on electrical impedance. And the third line, we see the compliance variation. In green, we have the gain in compliance of each step. And here we have several criteria. On the first up, on the top part, we have compliance measured by electrical impedance tomography that sees complexity compliance. And at a baseline, we started a right compliance of 15 and the left lung of 10. We do lateralization with the left lung upward when we return to supine, and we see that the left lung that underwent greater pressure with lateral position increased from 10 to 12. We go back to, in this case, to lateralize the contralateral lung, and we see that the right lung went from 15 to 17. So at the end, sequentially, we have achieved an increase of the compliance of each lung. And this is translated into the overall mechanic in case of compliance of the respiratory system. It increased from 25 to 30, and the radio impedance went from 26 to 30. With better oxygenation, the PAFI to 110 to almost 170, And this is the reality of what we did in this protocol. And another interesting thing that we looked in the tomography of electrical impedance is that there was a redistribution in aeration in the functional or in inspiratory. In this case, that aeration of the ventral areas was reducing, the non-dependent one that had greater distension, and increased in the dorsal or dependent areas that suggested that there was recruitment of those areas. And all of that was accompanied by improvement in global and regional compliance, both in the anterior area as in the posterior area. We also documented with ultrasound, we used two scores, the U score and the consolidation score, that patients improved pulmonary aeration using this method, beginning supine 1 with the end in supine 3. Only of the 15 patients, there was only one of them that did not respond to the maneuvers, or in other words, did not maintain the gain in aeration as a product of the postural maneuvers. So to summarize the results of our study, we see here that basically in this sequence, the overall and regional respiratory mechanical improved, the gas exchange, there was a redistribution of air in the ventral to the dorsal areas with a reduction of consolidations measured by ultrasound. What's interesting perhaps of this technique is that all of that was achieved without increasing the airway pressure, as often happens in a classical recruitment maneuver. And what we also saw was that there was very good tolerance in terms of hemodynamics and stability of the gas exchange. However, a final message here to finish. Can you see the video? Is the video running? To the left, I have the beginning of the sequence, large consolidations in the posterior areas. And now I lateralize the patient in lateral left decubitus with the left lung upwards. I hope you can see the video. And we have an increase in aeration of that posterior right zone. No, the video is not running. Don't worry, you can continue. Let me just try. Okay. It's not going to run like a video, but at least you can see the images. Just to exemplify how vital it is to program an adequate level of PEEP. To the left, we start the sequence of lateralization, extends areas of collapse of the posterior regions, zone 6, and from 6 to right here, we lateralize towards the lateral decubitus with the right lung upward, and we have more air, not totally, but there's more air in the 6 dorsal right area. But when we return the patient to supine position, everything that was gained was lost. Once again, there's an extensive zone of consolidation. Now we do the opposite. We lateralize towards the right, in other words, with the left lung upward. And we can see that once again, there's more air. So it works like a recruitment maneuver. We are able to open those alveoli, the collapse alveoli, but when we return once again to supine, everything is lost. That is why we were saying that it was fundamental, and this is still a reason for more studies, that the program PEEP is fundamental for the success of this maneuver. In this study, we use the recruitment ratio proposed by Professor Rosard, and arbitrarily, to make it more simple, those that had a high index or potential of recruitability, we programmed a PEEP of 15, and those that had low potential, the PEEP was 12 too. And this worked in all patients with the exception of one. And the final message, this is an interesting technique, but that is still very preliminary. We need to consider that even though we have encouraging effects, we have to study certain things still. We still have to look at the optimal PEEP level to be applied during this technique. The duration of the maneuver, we only did it during 30 minutes. A physiological issue, it might require more or less. It will depend on the patient. The duration of the observed benefits. So because of all of that, we have to be cautious when we extrapolate these results to the general population. Basically, that was it, Professor. And thank you. Excellent talk. Excellent talk. Of course, it's introducing a new technique that is simple, that produces very little harm to the patient, and that we're probably not using, or we're using when nursing position change position, and that can help. I don't see if that we have any questions. And then we will ask questions to Dr. Roldan as to Dr. Ceccato. It's also a pleasure to present Adrian Ceccato, pulmonologist, that will talk a little bit about something past, but that we all have very present, which is that we have learned from COVID, from the data from the CIBERES ICU COVID. So Adrian, the floor is yours. Well, good afternoon, and thank you, Luis, for this presentation and for this invitation to participate from this very important and beautiful event. I will talk about one of the last papers that we have published with the data of CIBERES ICU COVID, how we did the clustering and how the clustering process changes in distress secondary to COVID over different days. I don't have any disclosures to declare, any conflicts of interest. And as you know, there are several strategies or several treatments that have gone by in testing efficacy in respiratory distress. And because treating all patients the same is a mistake. So this strategy in one size fits all has not worked. So what is proposed now is personalized medicine. And this personalized medicine, we have to know how to choose patients to be able to individualize. Distress is a heterogeneous condition. We know that it's different diseases that can cause it, infectious, inflammatory. It can be direct or indirect damage. And we can group patients according to the degree of hypoxemia or to different histologic stages that have been described in this distress, ARDS. We can see how two endotypes have been formulated depending on the genomic signatures in patients with sepsis and community acquired pneumonia, which is the main cause of distress. And we can see that endotype 1 has relative immunosuppression. We can see tolerance to endotoxins, that T cells are exhausted, that there's downregulation of the major histocompatibility complex. And in endotype 2, which are patients that are relatively immunocompetent, there's an upregulation of this histocompatibility complex with an improved immune function and with more bacterial clearance. At the bottom, we can see the two mortality curves, both in the cohort that these endotypes were described and they were validated, where we see that endotype 1 has greater mortality or lower probability of survival. FEPIMCTI described two supertypes based on inflammation, inflammatory parameters, and has called them subphenotypes that are inflammatory or hypo or hyperinflammatory. The hypoinflammatory are the ones that have lower levels of IL-6, IL-8, or the TNF receptor, and also protein C, and a high bicarbonate. And the hyperinflammatory has high levels of IL-6, IL-8, or TNF-R receptor, and low bicarbonate and protein C. And patients with hyperinflammation, the hyperinflamed patients have a higher mortality and lower free ventilation days. The identification of these conducted assessing the efficacy of sympathizine in patients with distress. And we can see that at 28 days, as at 90 days, there are no significant differences between the placebo or the treatment arms in patients that had a hypoinflammatory subphenotypes, but in the ones that have hyperinflammatory phenotype, there's a significant difference between placebo and the treatment. So what we can see is the efficacy of simvastatin in hyperinflamed patients. The same type of analysis has been conducted with high levels of PEEP, and we have also seen differences between the hyper and hypoinflammatory phenotypes to manage fluids. The same group during COVID did the same analysis. This is a latent class analysis to describe these two phenotypes, and what they found is that the results they had were similar, but with certain differences, and they call them, for distress related to COVID, they call them class 1 or class 2. And what we see is that there are a certain amount of overlap between these different subphenotypes, but that are not completely the same. And once again, why is it useful to separate these two phenotypes? Well, what they saw is that both the ones that were class 2, let's remember the previous slide, and also the hyperinflammatory subphenotype, there was a greater response to corticoids, which sounds logical. And in these patients, there was a significant difference. And the opposite, in the hypoinflammatory one, or in class 1, we had greater mortality in patients that received corticosteroids and lower in the ones that did not receive them. There were also differences in the viral load in patients that died. There was a higher viral burden in the hypoinflammatory, and the differences between patients that died or not in the hyperinflammatory phenotype was not given, or there were no difference in the levels of the viral load or viral burden. And one of the questions that arises with clustering is when to do the clustering. If we measure any inflammatory mediator in the curve presented by patients with distress or also with other critical diseases, if we have a single measure, we don't know. This patient could be at a phase where inflammatory markers are elevated, or they could be reducing. So if the inflammatory markers were raising, we could think of an anti-inflammatory therapy. But if they're going down, that wouldn't make that much sense. So there are some studies that looked at assessing the trajectory of the subphenotypes over time. In the study by Michael Nutt, what we can see is that according to the different respiratory supports, the hyperinflammatory subphenotype was present in those patients that were receiving invasive mechanical ventilation, and less in those that were receiving non-invasive mechanical ventilation or ECMO. But was more interesting, and we need to highlight that this is a very low end, is that patients that were in the hyperinflammatory group on day 1 could switch both at day 5 or at day 10. And even though there was a lower proportion, those that were hypoinflamed could go back to being hyperinflamed. And the prognosis in these patients changed according to whether they resolved the inflammation and became hypoinflammatory, or if they persisted, or the opposite, if they emerged as hyperinflammatory. The group by Liebebos in Amsterdam analyzed 3 cohorts with a similar approach to produce subphenotypes of latent classes, but through a longitudinal study with data from several days, a different approach to the one we had been seeing. And what they were able to observe, they didn't find subphenotypes with just one analysis at a cross-sectional level, but just at a longitudinal level. And they described two subphenotypes. And as we can see, these are all respiratory parameters. The ones that marked a greater difference were the driving pressure, the ventilatory ratio, the minute ventilation, and the mechanical power at the level every single day. However, at a baseline level were the places where you could see the least amount of differences. And these subphenotypes, both in one that is the green or the red that is number 2, they followed the trajectory both of the mechanical power as of the ventilatory ratio, and the opposite, they didn't follow trajectories of the PAFI ratio or the respiratory compliance. So with all of this, we decided to go look at the database of the CIBERESUCI COVID database, and we wanted to evaluate how the clusterings of patients could change using data at the beginning of mechanical ventilation or on day 3, and if this impacted the prognosis of those patients according to their evolution, if they change cluster or not. The CIBERESUCI COVID study is one of the largest studies done here in Spain. It was multi-center with more than 50 ICUs. It was prospective, even though the data of the first wave were gathered retrospectively. And in terms of the statistical analysis, we grouped patients with a mixed type cluster. We used continuous and categorical data because we believed it was also important to have categorical data, such as comorbidities that could not be used with continuous data, and the method was the K-prototype method. Of 6,200 patients included in the database, the main cause for exclusion was that they had not received invasive mechanical ventilation or did not meet the distress criteria. And we included data from 3,743 patients at a baseline level and 3,643 patients. So we only had 100 patients that were lost between the baseline and the day of intubation and day number 3. On these graphs, what we can see is the clustering at a baseline level, and on day number 3, we can observe that the variables that were the most different ones between clusters were age, glucose, creatinine, ventilatory ratio, PEEP, and some markers as the C-reactive protein or LDH. And on the other side, we see temperature, mean arterial pressure, the arterial oxygen pressure, and inspired pressure, serum. And in terms of comorbidities, we see hypertension, diabetes, or obesity. That is what we have seen described in other databases as well, because these were the patients that had the worst prognosis. And also the presence of the needs for vasopressors. On day 3, we see that the importance of some variables change, and ventilatory ratio marked the highest differences between the two groups. The peak pressure, creatinine, age, PEEP, and C-reactive protein. And on this other side, we see the mean arterial pressure, albumin, platelet count, oxygenation, and pH. And we see that comorbidities lose the weight they had before. So we see that the clustering process is different between one day and another day. And what happens when we wanted to look at the prediction of these clusters? We see that both on day one as on day two, they clearly predict mortality being significant at both moments. And for both curves, the curve of survival probability, a little bit better prediction in the clusters done on day number 3. And what happened with the patients that switched cluster? Those that we had first in cluster 1 and then went to cluster 2, they almost matched the mortality of those that remained in cluster 2. And the opposite, those that were in cluster 1 were the ones that had the best prognosis. And then those that switched from cluster 2 to cluster 1. So the parameters improved, both the inflammatory as the progression parameters. This is a better graph to see the amount of patients that went from one group to the other. We see that on day 1, 1,400 patients were in cluster 1 and 2,300 in cluster 2. That from cluster 2 to cluster 1, there were 638 patients and 458 that went from cluster 1 to cluster 2. And that mortality was higher, greater associated to cluster 2. And those that went to from cluster 1 were slightly lower. So the conclusion of this study is that during the first days of distress, patients can be clustered into 2 groups, and that the clustering process can change depending on how patients evolve. And that means that there are majority of patients that remain in the same cluster, but there's 32% that change and can be recategorized into different clusters, and that significantly impacts their prognosis. These were some studies that have been published after our study. What this shows are the subphenotypes, both on admission to the ICU as when they are discharged from the ICU. We see that there's a proportion of patients, a lower proportion, but there is a proportion of patients that remain as hyperinflammatory, and then the majority improves of the ones that had a hyperinflammatory parameter upon admittance and come to be hypoinflammatory when they are discharged from the ICU, and that those that had a hypoinflammatory subphenotype when they were admitted, only a minimum part of these, that was 0.05%, were hyperinflamed, but the majority remained in the hypoinflammatory subphenotype. And in terms of the persistence or solution of respiratory distress, what we see is that those that persisted with persistent respiratory distress, the majority presented not 49%, a more important figure from those that were quick responders, as hyperinflammatory subphenotype. So to categorize patients into hyper or hypoinflammatory allows us not only to look at mortality, but also how these patients will evolve with this distress. And 30 seconds, this is an analysis with longitudinal data. And what we see is that using respiratory compliance and SOFA, that those patients that persist with a high SOFA have higher mortality, a lower probability of survival. And the opposite, those that improve SOFA are the ones that have a higher probability of survival. And lastly, the conclusions of this talk in terms of the subphenotypes, I think that subphenotypes represent a significant advancement in personalized medicine. And the process of clustering and how to identify these subphenotypes We need to consider that changes are dynamic and that they can rapidly change, especially in these pathologies, the critical pathologies such as sepsis or respiratory distress. And I believe that we have to have longitudinal analysis with measures that are easy to done at the bedside of the patient, especially if the variables are stable. Because this is the other thing to consider, the mean lives of cytokines. And to thank you for the invitation once again. And this is the research team here in Partauli, and all those that have participated from the CIBERESUCI COVID, the cyber that has allowed us to do this study that has been one of the most important ones in terms of COVID. And again, Professor Torres, the principal investigator, and to be able to answer any questions that you might have. Thank you. But we only have 3 or 4 minutes. So I pray very fast answers. I will start with a question. Dr. Roldan, question that I will summarize. Why do you use lateral positions if prone is very effective? Well, if you keep the patient seated, if it would produce similar effects. Thank you for the question. Well, in the context of the pandemic, Peru was one of the patients that was in a worse situation, and to place patients in prone position during very long periods of time was not exempt of risk because we didn't have adequate places. The staff was not adequate either. And there's bias in terms of the report of the collateral effects of prone position, especially extubations, tube obstructions, and hemodynamic complications. In that context, we started to explore this strategy, and with interesting results. It doesn't mean that it will replace prone position. That is not the message of my talk or the study. But I think it's an interesting alternative in some patients. With regards to the position sitting down, that's a different story. To think it as a way for recruitment, not so much so. Perhaps in obese patients or patients that we want to ventilate on the weaning process, but as a recruitment maneuver, not so much so. In fact, it increases overdistension of the regions that are more dependent or dependent gravitationally speaking. Adria, I have a question for you. Of all this that you have mentioned, are all of these markers of subphenotypes easy to access for everybody, or what would you recommend when this patient is admitted? This is a question I have here, and I think this is very important. It would facilitate things if we had this at a point of care. How far are we from that? Well, we're still far from being able to categorize these patients easily. As I said, there are several methods in statistical terms to be able to do this. Not all of them are the same. But as we were seeing in terms of different pathologies, this process, this clustering process can change. We're still far. Another thing, as I was mentioning, is to consider that biomarkers are not stable and they can vary very quickly over time. So many times, if the results take too long, perhaps we're looking at a process 4 or 5 hours later, and the mean life of the marker already went by, and we don't have the same situation. So I believe that we still have a long ways ahead. And I do believe that the description of these subphenotypes is one step forward, that personalized medicine is the best approach for patients with critical diseases. But we're far from being able to take this to the patient's bedside. Thank you. We don't have time for any more questions, but I want to thank both speakers. I think it has been a very useful clinical session that will contribute answers to many clinicians that have problems at the bedside of the patient. And I will thank the audience that you're still here. The sessions are going to be recorded. You will be able to see them. You will have access to the questions, etc. So thank you very much. And I will see you all in the ARDS session next year. Thank you all very much.